Well, thank you, everyone. Again, good afternoon. Welcome to the concurrent session for D5, Addressing the Gaps in Gender Affirming Crisis Care. I'm going to get started in the interest of everyone's time as we continue to have people admitted through the waiting room. My name's Lindsay. I'll be your facilitator for this session. And before we get started, I'm going to review some quick housekeeping notes, and then I'll introduce our speakers and we'll begin. So first, I'd like to draw your attention to the bottom of your screen where you will find the Zoom toolbar. You can use the Q&A feature to submit questions throughout the presentation. We will review these questions at the end of the session and do our best to answer as many as possible in the time that we have together. Please ensure that your microphone is on mute until the Q&A portion of the session. Please note that we will be recording this session to upload to the conference website for future viewing by those who have registered for the conference, and you'll be able to access that platform for 90 days following the conference. I'd like to remind everyone that we have closed captioning for all of our sessions. Please click on the CC icon below the video window on your screen to access this function. We kindly ask that you complete the evaluation for this session by clicking on the session in the agenda on the virtual platform. There will be a survey button at the bottom of the session next to the join button, and your feedback is so appreciated, and it will be used to inform future events such as this conference. So please make sure we're filling that out. Also, we'd like to respectfully ask all of those attending today's session to engage with each other thoughtfully and always consider the impact of your words and interactions on others. As facilitators, we will not tolerate any abusive or inappropriate behavior, hate speech, and will ensure that anyone who engages in such behavior is removed from the session. If you've been disturbed or affected by such an event, please do what you need to do for you. Take a break, step outside, practice deep breathing, or reach out to someone that you trust. If you are in crisis and require immediate support, please click the FAQ icon on the conference homepage to access contact information for Connects Ontario. If you would like to report an incident, contact the event manager, Sherry Sim, by either clicking on the assistance button at the top right of your menu bar on your screen, or send an email or text Sherry. All of that information is there. So now that we have everyone in, I would love to move forward and introduce our presenters. I'd love to introduce to you Aedyn and Victoria, and they will go ahead and give you a more fulsome introduction as we dive into this session together. Thanks, everyone.
Thank you, Lindsay. I'm going to go ahead and share my screen here. There we go. All right. Everyone see everything okay?
Want to go full screen?
Oh. Good?
Yeah,
All
perfect.
Right. Great. So, all right. Good afternoon, everyone. Thank you to the Provincial HSJCC for inviting us here today to present on gender affirming crisis care. Before we begin, we want to recognize what an immense privilege it is to be here in front of you, presenting on the challenges for trans and gender diverse people within systems that are so complex that even us as service providers struggle to navigate sometimes. We're coming to you as two people embedded in these systems, and we recognize that we are speaking about a community whose experiences are often talked about, but that actionable and meaningful change is less often come by. We hope that what we share today can be a start, but that our work will continue beyond this presentation. So with that, we thought it would be a good idea to position ourselves.
Thanks, Aedyn. So my name is Victoria Peters. My pronouns are she and her, and I'm a white cisgender woman and have experience working in frontline and leadership positions at the individual, organizational, and system level with vulnerable populations. So I currently manage CMHA Waterloo-Wellington's mobile crisis team and our mental health and justice team. I'm also mom to a trans daughter who is 21 years old. Currently a university student, and I'm very interested in system navigation for trans and gender diverse young adults.
And my name is Aedyn Cressman. My pronouns are they, them, I'm a white trans masc queer person from Kitchener, Ontario, and I have experience working with vulnerable populations and crisis positions in Montreal, Toronto, Kitchener, Waterloo, and Guelph. In all of these cities, there's one thing that I've seen in common, and that's the ways in which the trans and gender diverse community gets cycled through community services and are often lost in the gaps. We're all operating in a broken system, and this community is being harmed in the process. We hope that the presentation helps you see past the surface level harm that the trans and gender diverse community face, but to also understand the ways in which this community is forced to navigate a system that wasn't meant to serve them.
So a quick note before we dive into what the goals for the presentation are. A quick note on terminology today. So today we're using the trans and gender diverse as an umbrella term for two-spirit, trans, non-binary, gender fluid, gender queer, agender, and gender non-conforming. We obviously need to use inclusive language because that definitely sets the tone for affirming care. We also want to note before we begin that within the trans and gender diverse community, there are intersections of colonialism, racialization, ethnicity, and abilities that all impact privilege and pose further barriers and discrimination. So we'll speak more about this during the presentation, but we just wanted to name that at the outset and for you to all bear that in mind. So for today, the presentation goals, certainly as you can see here on this slide, are to highlight the gaps in crisis care for trans and gender diverse individuals. We know that there's an overrepresentation with this population in crisis situations, including homelessness, poverty, justice involvement, mental health emergencies due to systemic discrimination and stigma. And yet they are a minority of the population. So the lack of gender affirming crisis support really perpetuates negative outcomes, suicide risk, substance use, poor health, and repeated system involvement. And so hopefully you may see this as even a call to action. We're hoping that through training and education, building safe spaces and systemic change, that we in a small way can build capacity for frontline workers, justice system staff, leadership, and we encourage you to reflect on your position and your own ability to affect change as you listen to this presentation. So now we'll throw things back over to Aedyn.
Yeah. So in order to understand the unique experiences of the trans and gender diverse community, we thought it would be a good idea to break things down. First, what does community crisis look like for anyone in the community, and how does it work? So community crisis response is not a one-size-fits-all system. People typically enter this into service through a crisis system, like the national or regional crisis lines or other specialized lines like Kids Help Phone, for example, or police. The next step is typically de-escalation. So crisis service workers are trained in risk assessment, suicide prevention, and nonviolent crisis intervention. Goals here are to de-escalate and also to safety plan, but police intervention may be needed in high-risk situations. If de-escalation is not possible, specialized teams bridge the gap of policing. They bridge the world of policing with the world of mental health. Mental health workers and nurses assess risk and try to divert away from escalation with police or hospital. If it's high risk, police can apprehend somebody under the Mental Health Act. And if there are reasons to believe that someone is at risk of harm to themselves or others, police can then transport a person to the hospital to be seen by a physician. And while at hospital, the person will be assessed and stabilized if needed. The outcome of hospitalization is typically outpatient support, which is where a connection to post-discharge follow-up happens. The second thing to understand about our presentation here is the concept of gender affirming care, which is a very broad term.
So the World Health Organization defines gender affirming care as a range of social, psychological, behavioral, and medical interventions to support and affirm gender identity. And some examples that you may be familiar with include gender neutral bathrooms, hormone replacement therapy, inclusive signage, inclusive language, the use of authentic names and pronouns, among others. But this needs to go beyond a checklist, and gender affirming care and crisis care in particular really needs to address systemic impacts. So healthcare, housing, income, and legal systems. And so we're trying to break things down today into the micro view versus more of a macro level view.
Exactly. So, I mean, how can somebody support and affirm one's gender identity if their experience on that macro level isn't acknowledged? Our definition of gender affirming care means that one's felt sense of gender is acknowledged and respected while recognizing the unique ways in which their gender impacts their care and experiences within the larger systems, which include healthcare, housing, shelter systems, income support, and the legal system, to name a few. And this is what brings us to this revolving door of crisis. Without the experiences of the trans and gender diverse community being seen through that macro level lens, this community will continue to experience this revolving door of crisis, and their levels of risk will continue to be misinterpreted, and the cycle will not be disrupted.
So when we talk about the revolving door of crisis, Aedyn and I have looked at 4 pillars of where these the revolving door is positioned. So as you can see here, the first one is how we'll start with housing stability. We go to then supports and services or lack thereof. We've grouped the 3rd pillar into mental health and substance use. And also the 4th pillar is the justice system. And so as you can see here, each pillar has unique risk factors and gaps for the trans and gender diverse population. But at each pillar, there's also an opportunity to disrupt the cycle. So what we'll do now is we'll walk through each pillar and highlight the gaps and the ways in which the trans and gender diverse community experience them. Then we'll move on to a couple of case studies, and then we have some solutions to present as well.
All right, so our first pillar here is how this community experiences housing instability. Their entry into it, the ways in which the shelter system further marginalizes this population, and the issue of underemployment, which places them at further disadvantage.
So in terms of entry into homelessness, when we talk about the trans and gender diverse communities' entry into this pillar, much like many other 2S LGBTQIA+ youth, a safe home environment can really quickly become unsafe after coming out. So 25 to 40% of the 40,000 homeless youth in Canada are 2S LGBTQIA+. And family conflict relating to their sexual orientation or their gender identity is actually the main cause. Trans people are twice as likely as their cisgender peers to experience severe poverty and homelessness.
So why is this? Well, traditional approaches for youth homeless prevention don't typically work in the same way for gender diverse and trans youth. This is an example of a homeless prevention model called Youth Reconnect, which has 4 key elements. The first being keep youth in place. This is enhancing a youth's connection to supports within their community, but this is very difficult for the trans and gender diverse youth because dedicated supports and services are pretty scarce. The second element here would be stabilize the living situation. This is done by addressing sources of conflict in the home, but when the major source of conflict is specifically linked to one's gender identity, the living situation cannot be stabilized without acceptance. When it comes to supporting youth and families, reconciliation of strained relationships is typically the goal, but this becomes a lot more complicated if a trans youth is facing the rejection of their gender identity. The last element is about enhancing school engagement. This is done through enhancing feelings of inclusion and connectedness. But gender diverse youth already have experience in having social exclusion within the school system. And so there might be an underlying mistrust within the school system to begin with. So what happens when someone who is trans or gender diverse enters into the shelter system? Well, the very binary nature of the shelter system forces this community to navigate a system that wasn't meant for them, and they're faced with a few possible decisions. First being the decision to invisibilize their identities to access a shelter that aligns with their assignment from birth, or they could face discrimination at the shelter of their authentic gender. A quote from some research about the experiences of trans and gender diverse people within the Toronto shelter system highlights this perfectly. Trans people walk a fine line between when it's worth asserting your identity and when you choose to keep your head down. It's a constant trade-off between your authenticity and your safety. The next decision is to purposefully alter presentation to seem more cisgender in order to access supports or as a way to keep themselves safe. So an example of this would be when a trans woman would have to remove her makeup or nail polish or keep her hair short in order to access services at a men's shelter out of fears of being turned away from a women's shelter for not being woman enough, or for fears of violence if they were to access a men's shelter if presenting authentically themselves. The mental process of stripping your identity in exchange for safety is something that many trans and gender diverse people have to live with. Unfortunately, shelters are a space for normalized oppression. So the onus becomes on the frontline staff at shelters to make decisions about someone's ability to access services based on their perceived gender. The result of this is this concept of normalizing passing as a standard to access services. Passing would be the concept of being perceived as the gender they identify with. So, for example, a trans man being perceived as a cisgender man. The problem with normalizing passing is that if someone is able to pass, they then have to live their lives with the looming fear of being outed and the very dangerous consequences of that. The overall result of treatment in shelter is avoiding the shelter altogether. Many trans and gender diverse people engage in survival sex or return to abusive situations, which only increases their risk of violence. And more importantly, they don't get to access the services meant to transition people out of homelessness, which only adds to the cycle of housing instability and increases rates of hidden homelessness.
And so another really contributing factor of long-term housing insecurity for the trans and gender diverse population boils down to employment status, underemployment, and under opportunity. And so when we look at the statistics from the trans and gender diverse population, there are significant rates of underemployment for a variety of reasons, which, as we said, contribute to housing insecurity. So a couple of things that you can see here, there's the high prevalence of workplace discrimination. Up to 72% of two-spirit, non-binary, and trans individuals in Canada report experiencing workplace discrimination. Lower income, employment challenges, and identity concealment. Many trans and gender diverse individuals, similar to how this population copes within the binary shelter system, they face job rejection or termination due to their identities and often have to mask their identity in order to avoid discrimination or hide or minimize aspects of their identity. There's underemployment versus that safety trade-off. Sometimes individuals remain in underpaid or underemployed positions because their current employer is supportive, and that's a safer trade-off. There are structural barriers to employment, including obtaining valid ID and references, which are essential for employment, but many trans and gender diverse people struggle to obtain these documents reflecting their current name and pronouns. In 2015, an Ontario study found that 28% could not get references with their current name and pronoun, and almost 60% couldn't get academic transcripts with their current name and pronoun. So these barriers create practical obstacles, mental stress from having to come out or explain identity changes. In terms of income and housing instability, income is strongly correlated with housing stability. Another study in 2019 in Ontario showed that of 2,000 trans people, it was found that 50% live in low-income neighborhoods versus 37% of the general population, and many earn less than $50,000 annually. So we have this pink glass ceiling phenomenon whereby trans and gender diverse individuals are overrepresented in entry-level, precarious, low-paying jobs. And these roles often lack benefits, sick leave, paid time off, and limiting advancement opportunities and really increasing vulnerability. So in terms of real perspectives, real life perspectives on this, here are some quotes for you from trans and gender diverse people who have shared their experience and who shared their experiences in research. I'll just read one of them out. There was not really any way for me to be my identity and also work at the same time because the culture is quite toxic and very conservative. So you can see here that real world perspective and the real life lived experiences of people in this population in terms of their work status.
Okay, so our second pillar is a reflection of barriers faced with housing stability. When people are struggling, they are usually oriented to community supports that exist to lead them in a positive direction. But what happens when there's a gap in services and supports offered? We wanted to start with appropriate healthcare. Typically, hospitals and primary care are supposed to be the safe place to go. But due to an overwhelming lack of training and experience from the providers who hold the power of providing necessary healthcare, this is not the case. In fact, there's actually no standardized education for sexual and gender diverse people in medical schools. An example of this being that even practicing physicians in Winnipeg reported in a study that training was between 0 and 1 day per year throughout their schooling. And even at that, training is typically done under the umbrella of sexual and gender minorities. And when you think about trans needs in healthcare, they're completely separate from healthcare needs of anyone else within the 2S LGBTQI+ community. Now, the result of this is formal or informal discrimination. So this ranges from the refusal of care to the use of harmful and insulting language. This leads to an overall lack of trust in the healthcare system and a minimizing of healthcare needs out of fear of mistreatment. And so, the delaying access to healthcare can cause detrimental health effects. In fact, sexual and gender diverse people are 4 times more likely to have cardiovascular and respiratory diseases, arthritis, certain cancers, and sexually transmitted infections than cisgender heterosexual counterparts. And again, we wanted to share some common healthcare experiences. First being the concept of having to educate healthcare providers. In fact, a study in Waterloo region noted that 76% of trans people have had to educate at least 4 different healthcare providers. Another experience of having to suffer from having harmful and insulting language, the misgendering, the dead naming, questioning of gender listed on their IDs, and there's even been accounts of hospitals referencing their gender identity in negative ways. GPs refusing to treat or explore trans-specific healthcare is very common. This is under the rationale that these things are not their specialty, or they don't feel equipped to treat this, which is understandable considering the lack of training. But what this does is that it results in referrals to trans-specific clinics for specialized care, but these could be located hours away. Again, another barrier. And when primary care funnels referrals to the very clinics, to the very few clinics where this care exists, the wait list for those services completely skyrocket, which serves as a further barrier to care. There are reports of an exclusion of two-spirit non-binary needs due to the concept of transmedicalism. This is a bit of a wordy term, but essentially it's defined as the view that the trans identity is rooted in the experience of dysphoria, stemming from a feeling of distress from the incongruence between one's assigned sex and their gender identity, and that this can be treated through medical intervention. What this does is that it both encourages surveillance of trans bodies, but it also places a definition on transness that it's just not representative of many people. So, for example, many two-spirit people may not identify with Western concepts of gender that were imposed onto them, and therefore they might not experience dysphoria in a way that medical professionals believe is necessary to get gender-affirming care. The similar could be said for many non-binary individuals who want to have gender-affirming care but not wanting to transition in a binary way. This leads to the automatic pathologizing of gender, which diverts focus away from other healthcare issues that they, just like everybody else, experience. Because the healthcare has been constructed in a very binary way, it assumes that there are two gender categories of women's health and men's health, and that they align with certain bodies, which unfortunately leads to non-inclusive practices. Like, for example, when we think about preventative healthcare, reminders for cervical screening pap tests are mailed province-wide to all those with an F gender marker. And unfortunately, that just excludes a lot of the population who may have gender-neutral markers, for example. Or something to consider is that a trans man or masculine presenting person would also be in need of routine preventative screening, but it may be more difficult for healthcare providers to routinely consider this, given that tests are typically directed for women or feminine presenting people. Affirming healthcare require physicians to address automatic assumptions about gendered healthcare, and this is a very difficult task in a system that relies so heavily on a binary. And this is what brings us to mental health care and supports, where there's a clear gap in care. For example, a great study done by CMHA highlighted two very interesting things when it comes to outpatient care following hospitalization. First being that this community is 20% less likely to have mental health follow-up after a psychiatric admission compared to their cisgender counterparts. And the second finding is that after an ER visit, trans and gender diverse people were referred to follow up with their primary care provider within 30 days of accessing the ER at almost double the rate. The study suggests that trans and gender diverse people receive less mental health follow-up because they may have had an overall more negative experience during the hospital admission, which makes them much less inclined to follow up from supports from the hospital. And when being referred back to primary care, it's very likely that there are less follow-up options for their needs, and therefore GPs are the ones that are put in charge of exploring these. But as we know, this is not a very viable plan because primary care providers may not be aware or knowledgeable about trans-related issues. We also want you to keep in mind that this study was done in Toronto, which is one of the few cities in Ontario that have a gender identity clinic where support is available for the trans and gender diverse community. And smaller cities do not have the same ability to refer to targeted services such as this.
And thanks, Aedyn. That brings us now to our third pillar. So we've reviewed housing insecurity, supports and services, and now we want to talk a little bit about mental health. So when trans and gender diverse people are facing challenges, as we mentioned with the housing instability, discrimination, and lack of appropriate supports, it's understandable to see how severe mental health and substance use becomes a primary barrier to disrupting the cycle of crisis.
Yeah, we've encountered many examples where discrimination and stigmatization exist for this community. But when those experiences happen repeatedly, they can be internalized, which contributes to something called minority stress. These are the stressors based solely on their minority status and are experienced in addition to the stressors that everybody else faces on a given day. Minority stress is made up of a few different concepts here. So that's the internal stress. So that's the internalization of society's prejudice. There's the anticipated stress, so the anticipation of negative reactions or experiences. And then there's the actual external stress, which is the experiencing of that prejudice and bias. What this does is that it reinforces the exclusion and marginalization experienced while also reenacting this mental load and hypervigilance that happens in almost every interaction. So examples of this can be assessing if it's a safe place to disclose gender, identity, or pronouns, if it's possible to use the bathroom safely, if their gender identity may be revealed without their consent, or being misgendered or referred to by the wrong name. Minority stress is something that lingers in someone's body. Those pangs of rejection, hopelessness, feelings of being misunderstood are constantly felt. It's no surprise that there are a disproportionate amount of trans and gender diverse people resorting to substance use in order to cope. Minority stress is one of the key drivers for substance use among the trans community, followed by mental health challenges and social exclusion and victimization. A large study in 2022, based on almost 4,000 people, indicated that 90% of participants had used substances, 48% of them to make them feel better about their lives, and 68% as a way of self-medicating. And of note, it is difficult to get an accurate representation of substance use within populations who are also experiencing significant poverty, which often precipitates substance use. So there's a huge gap in research there. Another massive factor resulting in mental health and substance use is an increased risk of violence and victimization. According to Statistics Canada, 59% of trans and gender diverse people experienced violent victimization, and they were more than twice as likely as cisgender people to have experienced unwanted sexual behaviors in public places. When looking at intersectionalities like Indigenous identity, racial identity, and poverty, these numbers get even more staggering. We wanted to focus in on intimate partner violence due to the disproportionate rates and the significant barriers to accessing supports that continue to reproduce the cycle of abuse. Trans and gender diverse people experience institutional erasure. So IPV is seen as a very cisgender and heteronormative issue, which increases risk of being mistreated or misunderstood due to a gender presentation or sexual identity that fits outside of those boxes. There are massive barriers in accessing supports. Trans people lack appropriate services due to a very women-centric view that dictates victim supports. Like, for example, as of 2020, Toronto's shelter management information system, which is used for every single person. Here for Ontario, we talked about the which is used for every single person entering the shelter system, referred to the experience of sexualized violence in IPV under the acronym of VAW, which stands for Violence Against Women. In order to access support for these services, gender diverse people assigned female at birth and trans men needed to literally misgender themselves in order to access services. And masculine red trans people reported to be met with a lot of suspicion or asked to justify themselves in exchange for these dedicated services. When it comes to the use of police, there's an overall resistance to reporting incidents of IPV or involving police out of the anticipated stress of experience of being minimized, facing gendered stereotypes, or that their abuser may not be arrested due to the gray area in the procedures of identifying the primary aggressor. This, in addition to intersecting identities like race, Indigenous ancestry, histories of trauma, and past experience with violence and victimization, it's very clear to imagine how it's both unsafe and out of reach financially to leave abusive IPV situations. Because there is such a high rate of IPV, researchers have studied ways in which that this might look different for trans people than cisgender counterparts. In fact, there's a specific type of abuse widely experienced called transgender-specific intimate partner violence, or TIPV, which are tactics used by an abuser aimed at weaponizing transphobia. The most common ways that this plays out are through hiding or sabotaging hormones or gender-affirming items, intentionally misgendering or dead naming, threatening to out the partner, or telling the partner that they're not properly embodying their gender. The most at-risk population here are older trans feminine adults, specifically with a history of sex work and food insecurity. And a staggering 78% of individuals interviewed reported this experience. It's very sad to say, but this abuse tactic wouldn't exist if it weren't for the existing transphobia that already exists in society. Everything that we have talked about up until now should highlight reasons why trans and gender diverse people experience extremely high rates of suicide. But we just wanted to note on this as well. International studies have reported a 2 to 5 times the rate of depression and anxiety among trans people, and 10 times the rate of suicide attempts compared to cisgender individuals. Within Canadian research, there's a reported more than 5 times more likely to attempt suicide and have mental health concerns. And another Canadian study has found that trans people are 2 times as likely to think about and attempt suicide compared to those within the lesbian, gay, and bisexual communities.
Okay, and onto our fourth and final pillar in the cycle of crisis that contributes to the revolving door, which is justice system involvement. So there's a couple of different Canadian bodies of research that speaks to the experiences of trans and gender diverse people within the justice system. And both of them identify the same ways in which people come into contact with the police and the law. So again, entrance into the system is through housing instability, violence, as Aedyn described, mental health crises, and increased police contact. The criminalized economies like sex work and drug trafficking, drug dealing leads to increased police surveillance and profiling. And so police are viewed not only as enforcers for legal consequences, but they're also sources of harm and violence for the trans and gender diverse community. Due to, as you can see on this slide, there have been widespread accounts of negative experience. There's historical mistreatment by law enforcement that has been well documented, particularly for Indigenous, Black, and racialized members of this community. And so trans people report higher levels of violence during interactions with police, limited access to justice, as Aedyn has already described. Trans sex workers face the most severe outcomes. And then again, common patterns, including misgendering and name calling by officers, the dismissal of complaints or failure to take issues seriously. And then there's the direct discrimination and acts of violence. And so these experiences create collective fear and trauma toward law enforcement, which often leads to the avoidance of police involvement, even in emergency situations, and a reluctance to report crimes or to seek help, which only increases vulnerability. In terms of the correctional system, there have been policies that have been put in place to have placement for trans and gender diverse individuals by gender preference, and there have been affirming protocols put in place. But there have been challenges with this in terms of inconsistent implementation, officer concerns, calls for separate wings. You know, it's a small population, but there's a high level of discrimination. Trans and gender diverse individuals only make up 0.4 to 3% of incarcerated population, and yet experience disproportionate discrimination and violence. So in terms of policy advancements, in 2017, there was Bill C-16, which amended the Canadian Human Rights Act and the Criminal Code to protect gender identity and expression. And so that resulted in Correctional Services Canada making policy changes. So placement in federal institutions could be based on gender preference, not anatomy or ID, except for overriding health and safety concerns. And then there were individual protocols developed as well during intake with offender involvement, which covered respecting gender identity pronouns expression, housing preferences, the choice of staff for strip searches, options to integrate into general population or to remain in isolation, access to appropriate clothing and gender affirming items, private showers and toilets, and inclusion in correctional programming. But follow-up findings indicated that out of 99 gender diverse offenders, 47%, by the way, of whom were Indigenous, which highlights intersectionality that we've mentioned previously. 62% were trans women, 21% trans men, and 17% identified as other. Only 75% of them had individual protocols, despite the policy requirements. And in addition, officers felt comfortable providing care, but raised concerns about the increased risks to trans and gender diverse individuals in terms of victimization, pregnancy, strip search challenges. And at the end of the day, 44% were unsure, 33% were unsupportive of how to prioritize gender identity in placement. And so the policies were, excuse me, were seen as unclear and over-reliant on the use of discretion. So there have been some proposed solutions in some countries like Italy, the United States in Los Angeles County, for example, New Zealand and England. There are actually separate wings at some institutions for trans offenders. But at the end of the day, despite the policy progress, there are implementation gaps, safety concerns, and those experiences of discrimination and uncertainty persist within correctional settings. And then on top of that, there are post-custody barriers, as we've discussed, the housing instability, lower incomes, and that persistent stigma hinders that reintegration process.
And this is exactly what brings us back to the start of our cycle of crisis. As Victoria had said, all the factors that have led to justice system involvement to begin with still exist when a person exits custody. So these barriers to housing, income, access to supports are even further impacted once criminal charges are involved. And also negative experiences within the justice system may further impact mental health in a negative way. This is what makes the disruption of this cycle so critical. And in order to showcase this, we wanted to review some case studies that have been based on experiences reported by a variety of trans and gender diverse individuals.
Okay, so our first case study is Ari. Her pronouns are she, her. She's 27 years old, and her identity is as a trans woman. So Ari's parents immigrated from Iran to a small town in Canada when she was 12. She grew up speaking Farsi, struggled within the school system when she came to Canada. When she came out to her family as trans at the age of 16, she was told that her choice brought shame to the family. So she was kicked out of the family home. She moved to a bigger city and was directed to a male youth shelter. She tried to keep to herself. She feared that she would face violence, so she was constantly on guard and felt safer in accessing women's shelters. But because she was not passing as a woman, she was asked to justify her presence there. She's experienced stigmatization from other women in the shelter and was constantly misgendered. In terms of her healthcare, she can continue to be connected to her family doctor, who is Farsi speaking, but didn't feel comfortable exploring gender care because of the stigma within the culture. She began earning money by engaging in sex work. She became very recognizable and a known person in the downtown core and started to have increased police contact. She had many instances of being badly assaulted by others on the street or by clients, but never felt that she could report her assaults to police out of fear of not being believed or that she would be in trouble with the law. She then began to experience traumatic flashbacks and had difficulty sleeping. She began using alcohol heavy to cope and found it to be the only way to shut her brain off. She continued on like this for years and spent many days in custody on and off for thefts and breaches on conditions. Sometimes police would apprehend her under the Mental Health Act for threats of harming herself during an arrest, but she was never provided with appropriate outpatient supports. So now we ask, what if? What if the cycle was disrupted, and where could we have Ari's cycle of in the revolving door of crisis have been disrupted? What would this have looked like, and how could her income be or her outcome be different? So had Ari's parents allowed her to remain in the home, she could have completed high school, found community and connection through online friends, support groups. At the shelter, staff training could have provided Ari with an affirming needs assessment. There could have been plans to support Ari with accessing a private bathroom, gender affirming clothing, which could have made the shelter more safe for her to remain in. She could have been connected to a community health center for primary care that had a program for gender affirming care consults, peer support groups. She would have been treated with respect and given the opportunities to explore her gender identity openly. Even if she continued to experience symptoms of depression, struggled with that internalized transphobia to work through, she could have been referred to a social worker through the health center who has experience with gender issues. And if Ari was able to meet friends through support groups, she could have formed a chosen family and together would have been able to rent an apartment with these friends. So what we encourage you and invite you to do as you're listening to this case study and to the next case study that Aedyn will describe is to think critically, to name those issues that people are actually facing to get to solutions and disruption of the cycle. So when we name those systemic pieces like housing instability, lack of supports, shelter oppression, we can then develop solutions and work to disrupt the cycle.
We do have a second case study here, but in the interest of time, I want to make sure that we can review some other things and kind of those concrete ways that we can support as service providers. So we're going to skip past Ty here. That's all right. Coming back here, we've prepared these handouts. You will get them somehow, I'm sure. Feel free to screenshot if you would like. But this is just essentially a summary of what we've discussed. And we wanted to create a more concrete way to work with someone who is transgender, diverse, and experiencing crisis. So, like I said, these will be provided to you. But it's been split into those general guidelines, some tips during de-escalation, tips after de-escalation, and some kind of important things to know. And when it comes to general guidelines, we want to really stress that it's really important to use gender neutral language until pronouns are shared. You don't want to start crisis de-escalation with a conversation about pronouns as a way to build rapport. It's really important to address the crisis first. That conversation can be had after de-escalation. We really want to stress not to assume that a trans or gender diverse person wants gender affirming care or surgery unless this is really stated. Educate yourself. A transgender diverse person should never have to educate you, especially in times of crisis. And we stress to really understand how intersecting identities further influence risk factors. And remember that the presenting crisis may not directly be related to the gender identity, but it's very vital to understand how their experience as a gender diverse person led to crisis and affects the outcome. Some quick tips during de-escalation. It's really important to acknowledge that you will make every effort within safe parameters to avoid police or hospital contact. Can normalize that substance use is a form of coping, and inquire if there is any substance use that had prompted crisis. And after de-escalation, that's when you prompt client about pronouns. It's not just asking what pronouns are, but also inquiring if there are any safety concerns about those pronouns, or if they use those pronouns around everybody. It's important to ask if a client would have any other names documented. If yes, it's okay to ask if support's needed to help change or replace IDs, because it's a very difficult process. And when making a safety plan, let's keep in mind kind of what's going on with the GP. Prompt questions about the GP. Does your GP know about your gender identity? Do you feel comfortable with them? It's okay to be curious about those negative experiences within the shelter, healthcare, or legal space. And also, it's important to clarify if a stated friend is actually a friend or if they're a partner. and to see if that's a safe person for them. And you'll see at the bottom here, questions matter. Instead of asking, what are your pronouns? You can say, hey, I didn't catch your pronouns earlier. Mine are they, them. What do you prefer? Or instead of saying, do you have access to HRT, hormone replacement therapy? Say, are all of your healthcare needs met? We do also have some resources that we have collected that we can make sure come out to you guys as well. But I just wanted to pass things over to Victoria for some concluding remarks.
So at the end of the day, trans and gender diverse people deserve to exist in a world where healthcare and gender affirming crisis care is accessible, where their safety isn't compromised for simply existing, and where we can see and appreciate the beauty and differences amongst us. It is about cultivating a community of love for one another, where it is safe for people to be who they are without judgment, and where barriers to care are acknowledged and removed. So we thank you for listening as we seek to build capacity and to move towards culturally competent, trauma-informed, and affirming care within all aspects of healthcare for trans and gender diverse populations, with the ultimate goal of reducing the individual and systemic impacts of crisis situations. So we'll end with a quote from Alok Vaid-Menon, who is a non-binary poet, public speaker, and comedian. Alec has stated, there's magic in being seen by people who understand. It gives you permission to keep going. Thank you.
Yeah. We'd love to open up the floor to any questions. I'm not sure if there have been any, but.
And there's our emails. Feel free to connect with us. The PDFs of the resource sheets and the just the tip sheet are available. I think we'll be posting them here, but we're also happy to email them out to you as needed. So I don't know if there's any questions in the chat. Mine is blank. Or maybe it's not. Maybe I'm just not looking at the right place. But I don't know, Lindsay, if there's anything.
I'm just taking a look here. We don't have anything coming in right now, so it's
Okay.
fantastic that you were able to share your contact information, should anybody have questions going forward. Thank you so much, Victoria, Aedyn, thank you for this great presentation and for sharing such a wealth of knowledge and so much information. For all the participants that are here, please take a moment to fill the survey in for the session. You can do that by clicking on the agenda in your platform. Choose the session that you're in, so it's D5. Next, the join button, that's where you're going to find the survey. So agenda and join, and click on the survey button and complete that short survey. We encourage you to take some time to connect with fellow participants and visit our poster and exhibitor halls where you can view poster presentations and connect with our exhibitors. Also, we'd appreciate it if you could take a few moments to complete our conference evaluation, and you can access the conference evaluation by clicking on the evaluation icon on the conference homepage in the menu bar. Your feedback's anonymous and it's very much appreciated. It's used to plan our future events. So thank you so much for that. Thank you once again to our speakers and to every one of you for your participation. Please join us for the closing remarks. Click agenda in the platform and choose the closing remarks. And you can click join and participate in that as we close out the day. Thank you so much, everyone.
Thank you.
Thank you, everybody. Take care.